Hello everyone, this is Dr. Ravi Kant Tiwari. Today I am going to discuss with you a topic in pharmacology called non-steroidal anti-inflammatory drugs. These drugs are called painkillers. Painkillers are of two types: aspirin-like drugs. These are called non-steroidal anti-inflammatory drugs. And the second group is opioids such as morphine. So today my discussion is focused on aspirin-like painkillers. These are called non-steroidal anti-inflammatory drugs. So these are non-narcotic or non-opioid or aspirin-like analgesics. They have analgesic, antipyretic and anti-inflammatory action. But in contrast to morphine and other opioids, they do not depress CNS and are weaker analgesics. They have no abuse potential and no physical dependency. And they act mainly at peripheral mechanism, and many of them are available as over-the-counter drugs. Means they can be purchased without prescription of a medical person. So as you know that inflammation, pain and fever, these are the three important parameters on which these drugs act. So from your pathology classes, you are aware that inflammation is a process that involves release of various inflammatory mediators such as histamine, bradykinin, prostanoids, serotonin, leukotrienes and platelet activating factors. So mainly prostaglandins are the important mediators of inflammation apart from histamine and bradykinin. So these drugs, non-steroidal anti-inflammatory drugs, they are basically inhibitors of prostaglandin synthesis, as I will show in next slide. So they inhibit or reduce the process of inflammation. Pain or algesia is due to stimulation of nociceptors and pain receptors, and some stimuli such as heat, acids or pressure and some inflammatory mediators, they can increase the sensitivity of pain. So by acting on these mechanisms, by inhibiting these mechanisms, mainly prostaglandin synthesis inhibition, these drugs subside the pain perception. Similarly, fever is also due to altered set point of hypothalamus due to release of certain cytokines such as interleukins and tumor necrosis factor. So these drugs, non-steroidal anti-inflammatory drugs or aspirin-like analgesics, they basically act as anti-inflammatory action, analgesic action and antipyretic action. But some of the members such as paracetamol, which is the most commonly used drug in this class. In fact, everyone has used paracetamol in some phases of our life. So paracetamol is basically having analgesic and antipyretic action with very less anti-inflammatory action. But most of the drugs in this category, they have all the actions such as analgesic, antipyretic and anti-inflammatory except paracetamol. So you can see in this slide that prostaglandins are generated via arachidonic acid by cyclooxygenase pathway, and these drugs, they are the COX inhibitors, means they inhibit the process of formation of prostaglandins from arachidonic acid. By acting on these cyclooxygenase enzyme, they inhibit the synthesis of these prostaglandins which are involved in these processes. You can see in this slide that arachidonic acid is also converted via lipooxygenase pathway to leukotrienes, which are important in the pathophysiology of bronchoconstriction in bronchial asthma and COPD. So these drugs, non-steroidal anti-inflammatory drugs, these are basically cyclooxygenase inhibitors. Cyclooxygenase is the enzyme which exists in two forms, COX-1 and COX-2. So these drugs are classified as non-selective COX inhibitors, selective COX-2 inhibitors and some miscellaneous drugs. So aspirin is the prototype or batch representative of this drug, this class, aspirin, NSAIDs, and it is the irreversible inhibitor of COX, while other drugs are reversible inhibitors of COX-1 and COX-2. Some COX-2 selective inhibitors such as COXIPs are also available in the market. Acetaminophen or paracetamol, as I have told you, it is having weak anti-inflammatory activity. It is having mainly antipyretic and analgesic action. Some studies points for COX-3 inhibition activity in paracetamol, but it is not seen in humans. So classification of these drugs is important for exam point of view. They are classified as non-selective COX inhibitors such as aspirin, which is salicylic acid derivative. Indole acetic acid derivatives are indomethacin, etodolac and solendac. Aryl acetic acid derivatives such as diclofenac, aciclofenac, ketorolac and tolmetin. Propionic acid derivatives ibuprofen, ketoprofen, flurbiprofen, naproxen. Enolic acid derivatives piroxicam, meloxicam, tenoxicam. Anthranilic acids are phenamides, mefenamic acid. Selective COX-2 inhibitors are celecoxib, etoricoxib and pericoxib. Analgesic antipyretic with weak anti-inflammatory activity, the drug is paracetamol. So as I have told you that cyclooxygenase is the enzyme which converts arachidonic acid into prostaglandins, and COX is present in our body in two forms, COX-1 and COX-2. COX-1 is that enzyme which is constitutive and it is involved in housekeeping functions, while COX-2 is the inducible enzyme and it is mainly activated in inflammatory conditions. So COX-1 is the dominant cytoprotective form, and inhibition of COX-1 accounts for gastric adverse effects and bleeding. Some selective COX-2 inhibitors are also available such as celecoxib, etoricoxib and pericoxib, and the rest of these drugs such as rofecoxib and valdecoxib, they have withdrawn from the market because of their side effects, especially cardiovascular side effects. So as you move to the pharmacokinetics of these drugs are rapidly absorbed by oral ingestion, and food delay their absorption and bioavailability of these drugs. Most of these drugs, they are highly protein bound in the plasma and they distribute widely throughout the body. They also go in higher concentration in the CNS and in joints, especially synovial fluid. Some drugs such as aspirin, they exhibit dose dependent kinetics, means at higher doses the rate of elimination follow zero order kinetics. One important feature to note about paracetamol or acetaminophen is that it is metabolized to a toxic metabolite called N-acetyl para-amine benzoquinoamine, and it can lead to hepatic toxicity, especially in alcoholics or malnourished person. So therapeutic uses of these drugs are antipyretic, analgesic and anti-inflammatory. Inflammation can be seen in rheumatoid arthritis, osteoarthritis, ankylosing spondylitis and gout. So these drugs are having anti-inflammatory action. They subside the inflammation and the pain process. Pain is of mainly two types: integumentary pain, that is the superficial pain or musculoskeletal pain, and visceral pain. So these drugs have mainly action on integumentary or superficial pains that arises from musculoskeletal structures. In visceral pain, especially opioids are useful, and in neuropathic pain, anti-epileptic and antidepressant drugs are useful. They reduce fever in most situations, and they are assumed to be cardioprotective, and this action, cardioprotection, is seen in low doses of aspirin from 50 milligrams to 300 milligrams per day. In that dose of aspirin, it causes suppression of platelet thromboxane A2 formation that is thought to produce cardioprotective effect. And this action is seen with aspirin only, not with other NSAIDs, because it is the irreversible inhibitor of COX. Then systemic mastocytosis. In this condition, there is excessive mast cells in the bone marrow and other sites in the body. So prostaglandins are released in higher quantity and they are responsible for flushing, vasodilation and hypertension. So addition of aspirin or ketoprofen can be useful in this condition. Niacin in high doses is used as hypolipidemic agent but it can cause facial flushing due to release of prostaglandins. So aspirin can be used to treat this condition. Then Barter syndrome, it is a rare disorder characterized by hypokalemic hypochloremic metabolic alkalosis with normal blood pressure and the hyperplasia of juxtaglomerular apparatus. So the process involves biosynthesis of prostaglandins. So treatment with indomethacin combined with potassium repletion and spironolactone can be helpful in this condition. It is seen in some studies that non-steroidal anti-inflammatory drugs, if used in patients of familial adenomatous polyposis, which is an inherited disorder characterized by multiple polyps in the colon, and they have tendency to develop colon cancer by 5th or 6th decade. So these drugs, NSAIDs, they cause cancer chemoprevention in this condition, familial adenomatous polyposis. Adverse effects of these drugs can be various kinds of adverse effects. So these drugs are not routinely prescribed. They are prescribed for the limited duration of time, and in some patients, for example patients of arthritis or inflammatory conditions, long-term therapy may be needed. So we have to use enteric coated preparations or very adequate amount or dosing of these drugs, because these drugs have a large spectrum of adverse effects such as gastrointestinal, such as abdominal pain, bleeding, constipation, diarrhea, dyspepsia, esophageal ulceration, gastritis, ulcers, hematemesis, nausea and vomiting. Renal manifestations in adverse effects include cystitis, dysuria, hematuria, hyponatremia, interstitial nephritis, nephrotic syndrome, polyuria, renal failure in advanced cases, renal papillary necrosis, proteinuria, salt and water retention, hypertension, and worsening of renal function. Similarly, cardiovascular adverse effects include edema, heart failure, hypertension, myocardial infarction, palpitation, premature closure of ductus arteriosus in the fetal circulation, sinus tachycardia, stroke. Platelets, these drugs inhibit platelet activation, so increased risk of hemorrhage. Hematologic adverse effects includes anemia, agranulocytosis, aplastic anemia, and hemolytic anemia. Hepatic paracetamol is main culprit for hepatic adverse effects, and other drugs also in this category can cause hepatic adverse effects such as elevated liver enzymes, hepatitis, hepatic failure, and jaundice. Similarly, they can produce neurologic adverse effects such as anxiety, anorexia, confusion, depression, dizziness, drowsiness, headache, insomnia, seizure, syncope, and vertigo. Hypersensitivity reactions in the form of anaphylactoid reactions, angioedema, severe bronchospasm, flushing, and hypotension can be seen. Dermatologic adverse effects such as exfoliative dermatitis, photosensitivity reactions, purpura, rash, Stevens-Johnson syndrome, toxic epidermal necrolysis, these are the rare but serious adverse effects can be seen. Respiratory adverse effects such as dyspnea and hyperventilation, especially with aspirin and salicylates. Analgesic nephropathy, this is a very serious side effect of these drugs, but it is seen on long-term administration of high doses of these drugs. So these animals, their number becomes very less, or they become extinct from the environment because of multiple organ failures, especially renal failure, due to consumption of these drugs in the dead bodies of humans and other animals. So these drugs have the propensity to cause a wide spectrum of adverse effects, so their use should be justified for a limited period only. Then one condition that is called Ray's syndrome can be seen in children, especially less than 15 or 12 years of age, and this is seen in infections, respiratory infections such as viral infection in children, and if such children are prescribed aspirin, then a condition called Ray's syndrome can be produced, where hepatic encephalopathy and such conditions are seen. So coming to the individual drugs in non-steroidal anti-inflammatory drugs, we have aspirin and other salicylates. Aspirin is the prototype of this group, and its pharmacological actions include analgesic action, antipyretic action, and anti-inflammatory action. Anti-inflammatory action is seen in higher dose, that is 4 to 6 gram per day, while antiplatelet action is seen at low dose, that is 50 to 325 milligram per day. And this is due to inhibition of platelet thromboxane synthesis. Then respiratory acid-base balance and electrolyte balance. Aspirin at therapeutic doses, therapeutic anti-inflammatory doses produces compensated respiratory alkalosis, but at toxic doses it produces uncompensated respiratory acidosis and metabolic acidosis. And in case of poisoning, death is due to respiratory failure. Metabolic effects of aspirin include enhanced cellular metabolism, increased heat production. Therefore, in case of aspirin intoxication, there is hyperpyrexia. Uric acid excretion in low doses, less than 2 gram per day, it causes urate retention, but in the dose range of 5 gram per day, it causes increased urate excretion. So it has unpredictable effect in uric acid excretion, and that's why aspirin is not used in the treatment of gout. Adverse effects of aspirin include nausea, vomiting, erosive gastritis, peptic ulcer, blood loss in stool, headache, confusion. Aspirin-induced asthma and sometimes nasal polyps may be seen. Hemolysis in G6PD deficiency, hepatotoxicity, Race syndrome, that is hepatic encephalopathy, analgesic nephropathy, high doses for prolonged use, and this drug is avoided in pregnancy because it can cause premature closure of ductus arteriosus in fetus. High dose for prolonged period, aspirin can cause salicylism or chronic salicylate overdose, but it is reversible on withdrawal of these drugs. While acute intoxication, it can be fatal at the consumption of 15 to 30 grams of aspirin, and poisoning can be accidental or suicidal. The treatment includes gastric lavage, IV fluids, glucose, external cooling, forced alkaline diuresis, hemodialysis in severe cases, blood transfusion, and vitamin K if bleeding occurs. So uses of aspirin are analgesic use, antipyretic use, anti-inflammatory use, acute rheumatic fever, rheumatoid arthritis, and as a cardioprotective agent in post-MI, post-stroke patients. In that case, low dose 50 to 300 milligram per day is used. So you can see that dose range in aspirin is mainly in grams per day, but the antiplatelet effect or cardioprotective effect is seen in low dose, that is milligrams per day. Then the most common used drug in this group is paracetamol or acetaminophen, and this is a very safe drug, especially in pregnancy also, but in some patients, such as in malnourished patients or in alcoholics, this drug can cause acute hepatic failure or liver toxicity due to production of a toxic metabolite that I have mentioned earlier, and that metabolite is N-acetyl para-benzoquinamine. So this drug paracetamol is the very routinely prescribed, and it is in fact available as OTC drug, over the counter drug, and I have mentioned in the previous slides that it has mainly analgesic and antipyretic effect with very less anti-inflammatory action. So the routine uses includes the dose range of 325 to 650 milligrams every 4 to 6 hours, and total daily dose should not exceed 4 grams and 2 grams per day for chronic alcoholics. Sometimes at normal therapeutic doses in chronic alcoholics, hepatic side effects may be seen. Paracetamol is also available in injectable preparation. So what is the treatment of paracetamol overdose? So the antidote is N-acetylcysteine, and N-acetylcysteine functions by detoxifying the toxic metabolite, that is NAPK, and it replenishes the glutathione stores in our body, and it tries to detoxify the toxic metabolite. So some other members in this class are Diclofenac. It is having mainly anti-inflammatory activity, and especially musculoskeletal joint pain, Diclofenac is preferred. It is also available in the gel preparation for topical application. Ophthalmic preparation is also available. The new drug in this group is Diclofenac. It is the congener with similar properties, and it is preferential COX-2 selective drug. Then indomethacin is having anti-inflammatory action predominantly, but it is having higher chances of side effects also. Then some COX-2 selective inhibitors. The drugs are called COXIBs, but very few of them, such as celecoxib and pericoxib, are available. The rest of the COXIB are withdrawn from the market because of their adverse cardiovascular effects. So we can summarize this topic as these drugs are mainly called painkillers, and they are different from opioids because they have no abuse potential. They are safe drugs, but if prescribed for limited duration, but if they are used for prolonged period, they can cause a wide range of side effects. So this is all about this topic, non-steroidal anti-inflammatory drugs. It would be helpful for you. Thank you so much.